Great. Welcome to... Pardon me?
A couple seats over here.
Great. I'd like to welcome you all tonight for coming out. It's a cold night, so I appreciate everybody coming out this evening. And this being what's left of Heart Month, as we kind of wind out the month, it was a pleasure to be able to come down and speak tonight. What I was interested in talking about are prevention issues. And the reason for talking about prevention is because it really is the only cure for coronary artery disease, and everything else is just a treatment. Be it bypass, be it angioplasties or stents, or be it medications, those are all treatments of the problem. And so the only cure really is going to be prevention. Coronary artery disease is the #1 killer in both men and women. I don't know if any of you had the chance to see the Oprah show this afternoon, but they had quite a show about women and heart disease in particular. So I'm glad to see that Oprah is getting out the word, as has the American Heart Association, that it's the #1 killer in women, just as it is in men. Coronary artery disease begins at roughly age 10. That may be a surprise to a lot of you. But what happens is those arteries begin to get laid down at a very young age with something called the fatty streak. That thing progresses, and then over a period of time, the atheromatous, or the buildup of material that plugs arteries, happens over a period of time. People ask me sometimes, well, how did this happen all of a sudden, or why did it happen now? Now we have a harder time to tell you exactly why today might have been the day you had the heart attack. But this is a problem that occurs very slowly. If arteries slowly were to close off, people would slowly get chest pain. And that's not necessarily the way it happens. You can be okay one day and not okay the next day, or okay 1 minute and not okay the next minute. But coronary artery disease actually begins about age 10. The other reason prevention is so important is because it costs a whole lot less to prevent problems than it does to treat problems. Like the old Fram oil commercial, you can pay me now or you can pay me later, and it's a lot easier to do things if you just take care of it with prevention as opposed to trying to treat the problem down the line. And really, ultimately, as I say, prevention is the only cure, and all else is just a form of treatment. It is important to understand the concept of risk factors for coronary artery disease. There's things that we call coronary artery disease where it's equivalent. Equivalent things to coronary artery disease I'll discuss. There's also major risk factors and things we call emerging risk factors. All these things are equivalent to having coronary artery disease or blocked arteries. If you've had a bypass, you know you've got blocked arteries. If you've had an angioplasty, you know you've had blocked arteries. A heart attack, if you have carotid disease, that's equivalent to having blocked arteries in terms of how we manage patients. Also, if you've had an aneurysm, what we call an abdominal aortic aneurysm. Also, people who have something we call peripheral arterial disease or blocked leg arteries. Those people have a high prevalence of also having coronary problems as well. Major risk factors that we look at, those are things like smoking. People who have high blood pressure. If your blood pressure is 140/90 or greater, you have high blood pressure. For men, if you're over age 45, you're at risk. For women, it's age over 55. Those people who have a low HDL of less than 40, you're certainly at risk for having heart problems. And other things such as a high bad cholesterol or LDL, something we call the metabolic syndrome. Metabolic syndrome would be people who aren't diabetic. We might call it pre-diabetic, but even that's a bad term. It's generally the person you look at and you say, boy, that person's going to have a heart attack. It's the ones who are typically have high blood pressure, high triglycerides, overweight, low HDLs. That's the group that we call something metabolic syndrome. Family history, we think of that as being important, but really a lot of that ties into some of these other things, such as cholesterol. It's not uncommon for me to see husband and wife, they're both eating the same foods. One comes in with a cholesterol of 300 and the other one's 150. They're eating the same foods in the house, and a lot of it has to do with genetics or ultimately your family history. Also, obesity and inactivity play a role in terms of diabetes and some of the other things such as the metabolic syndrome. Emerging risk factors, and you'll see stuff about this in the newspaper. There were articles published that looked at things called C-reactive protein, which is an inflammatory marker. And C-reactive protein is elevated in patients who might have arthritis or other inflammation, people who have lupus who might have inflammation. And we think what happens in terms of the heart arteries when people have heart attacks is that there's an inflammation in the blood vessel, and that inflammation may play a role in causing the heart attack at that moment. We can measure something called C-reactive protein. The problem is we don't know what to do with it yet. Do I put you on aspirin? Well, hopefully that's a good idea anyway. Do I put you on an antibiotic? If so, which one and how long? So we don't know what to do with it yet, but we do know people who have high levels of C-reactive protein or high markers for C-reactive protein are at higher risk to have heart attacks. Also things such as thrombotic factors, things that make clots. That would be another emerging risk factor. People who have high fibrinogens and those sort of things that are important to making clots. Something called homocysteine levels, and these are important. And there's really two arms to the vitamin theory in terms of how vitamins help to prevent heart problems. There's the homocysteine arm, which states that there's a chemical that builds up in the body that we call homocysteine. And some people have an enzyme that doesn't help to get rid of homocysteine. Their levels are very high. Their levels might be 145 or even 100, whereas normal levels should be less than 15. But there are vitamins that are helpful to help those enzymes get rid of homocysteine. Those vitamins are B6, B12, and folic acid. So those vitamins help to lower your homocysteine level. The other arm to the vitamin theory states that fats need to be oxidated in order to be laid down in the blood vessel wall. So if you take antioxidants, then that helps to prevent those fats from being laid down. And antioxidant vitamins are things like vitamin C and vitamin E. How about prevention? There really are two types of prevention that we're going to discuss here this evening. One is called primary prevention. So this is for people who have yet to have identifiable coronary artery disease, and we're trying to prevent it. So we're primarily trying to stop it. This would be, you know, the kids in our school systems. This would be young adults. This is the group that we're trying to prevent problems before they happen. And then there's secondary prevention. Secondary prevention looks at trying to reduce events in people who've already had heart problems. If you've had a heart attack, how do we prevent a second heart attack? If you've had bypass, how do we make sure you don't have another one? Those are issues that we call secondary prevention. So I'm going to talk about secondary prevention first, and then we'll talk about primary prevention. These are some of the things that we're going to talk about in terms of secondary prevention. Some of these will obviously overlap in terms of primary prevention as well. If we look at just smoking cessation, stopping smoking, why is it so important? And it is important not only for the patient to stop smoking, but also for the family. And what smoking does to the heart arteries is the toxins and the chemicals that are in smoke basically damage the blood vessels. And as they damage the blood vessels, it allows the cholesterol and other elements to get under the layer of skin that forms that nice smooth layer inside the artery, and then that's what helps to set up the blockage that you see later on. So it's important for the patient to stop smoking, but also the family, because if somebody in the house is smoking, it's very difficult to stop. It's also important to avoid secondhand smoke. We know that secondhand smoke is important to avoid, that it too is a risk factor for developing coronary artery disease. I was happy to report that I went to eat here before the talk and went into a restaurant here in Fairfield. It was nice to see they had smoking and non-smoking sections. It would be nice if they had no smoking completely, but maybe that will come later on. Also, it's important to provide counseling for stopping smoking, as well as providing medications to help with that as well. There's now medications. You may have heard of something called Zyban, which is also known as Wellbutrin, which also help with stopping smoking as well. There's also the nicotine patches to help with that as well. Blood pressure control. And I think we've been a little bit lax with our blood pressure control in the past. We used to say anything less than 160 on top was a fine number. And we really know that your blood pressure needs to be below 140 over 90. That's really the number that we're shooting for in terms of getting your blood pressure below that. Anything above that is too high from our standpoint in terms of trying to prevent heart problems. If you have congestive heart failure, or if you have something we call chronic renal insufficiency, we want that number even lower, less than 130 over 130 over 85. And if you're diabetic, we want it less than 130 over 80. So those are much tighter controls than maybe you're used to seeing in the past in terms of blood pressure management. In terms of lipid management, the first thing we're going to recommend to you is diet, to watch your diet. There's a number of diets out there. Just to give you a rough idea, the average American diet, 50% of our calories come in the form of fat. The American Heart Association recommendations are to have that less than 30% of your calories come in the form of fat. If you're familiar with the Dean Ornish diet, which is a very strict diet in terms of your fat calorie consumption, 15% of your calories come in the form of fat in a Dean Ornish diet, which is a pretty restrictive diet and very tough for most people to follow. It's great if you can, certainly can reverse heart disease as well, but it's a very tough diet for most people to follow. Just to give you a rough idea, if you just take a potato, which has 100 calories, and cut that potato up and make French fries out of it, that same potato is now up to 250 calories. If we cut the same potato up and make potato chips out of it, we're now up to 400 calories. So in a single potato chip, 75% of your calories are coming in the form of fat. They can still list on the bag cholesterol-free, which it is, but it's loaded with fats. So you got to be careful, obviously, when you go to the grocery store. But diet would certainly be our first recommendation in terms of lipid management. Exercise is important as well. Generally, it's recommended about 30 minutes a day for about 5 times a week. Daily would be great, but 5 times a week is certainly what's recommended. The other thing we look for, you know, they've taught people very well to watch your cholesterol below 200, that's where we want it. But the number that we really concentrate on is something called this LDL, which is the bad cholesterol, and we want to see your LDL less than 100. That's really the number we're shooting for. Exercise, we mentioned that 30 to 40 minutes, 3 to 4 times a week, daily is optimal. Weight management, there's something called body mass index, and there's charts that your physician has that can look up body mass index. I can tell you 18 to 25, I would not make the 25. I myself am over the 25. If your body mass index is over 25, the goal waist for males is 40 and for females is 35. Now, I know a lot of guys go around and say, you know, I'm wearing the same pants I did in high school. But they get that Dunlap disease when the stomach Dunlap over the waist, and they keep pulling it up like this. So I know what it's like to be doing that sort of stuff. But yeah, you can't just keep getting the same pair of trousers you wore in high school and get everything to go, you know, over the belt line. So you got to be careful with that. So you actually measure it where your real waist is, not where you want your waist to be. And for males, it's a waist less than 40 is optimal, and for women, less than 35. Diabetic control, obviously a major risk factor in terms of the development of heart problems. Also certainly changes sometimes how we manage those patients, because we know that diabetics don't always do as well with balloons or stents. And so they may be referred to bypass a little more readily than other patients, particularly if a diabetic has more than one artery blocked. You want something called the hemoglobin A1C less than 7%. The hemoglobin A1C is sometimes called the 60-day blood sugar or longer blood sugar, and what it really does is it kind of averages your blood sugar out over time. You know, in the old days, we used to just check a fasting blood sugar. Patients would come in, this was before they had home monitoring even, and we just check your blood sugar in the morning. And that was great, but patients want to look good for the doctor, so they manage their diabetes in the day or two prior to coming to the doctor, and they get their fasting blood sugar checked, and it was 110, and they said, great. They'd promptly go out and eat the wrong stuff and probably had their blood sugars up to 280. So now what we can do is we can do something called the hemoglobin A1C, and we know how your blood sugar's been on average over the past preceding 60 days. How about aspirin? Aspirin's important. I put down the dose as 75 to 325 milligrams. We don't know the right dose of aspirin. It's probably anything over 100 milligrams and up to 325 milligrams. When I was doing my residency, if you had bypass surgery, you took 3 aspirin a day. In the United States, we did trials that looked at how much aspirin to give, and in the United States, the lowest dose aspirin that was used was 325 milligrams. In Europe, they did similar studies, and they found out that a baby aspirin was all you need. But the problem is that a baby aspirin in Europe is 100 milligrams, and a baby aspirin in the United States is 81 milligrams. So is 81 enough? Probably, but I don't have that data to tell you that. I can tell you 100 milligrams is plenty. If people can't take aspirin, there's a new medicine out called Plavix. It's kind of a super aspirin. It does inhibit platelets. It's also super expensive. We also give Warfarin or Coumadin to patients sometimes if they can't take aspirin or Plavix. Just a piece of trivia with regards to Warfarin, in terms of how it's got its name, those of you who are out on the farm know Warfarin is rat poison, and that's what it is. And so if we don't tell you it's rat poison and the neighbor does, that looks pretty bad. So we make sure that you know before you leave the hospital, if you're taking Warfarin, it's rat poison. But Warfarin got its name because it was discovered up at the University of Wisconsin at a building called the Wisconsin Alumni Research Facility. So the WARF of Warfarin stands for the Wisconsin Alumni Research Facility. Something called ACE inhibitors. This is a big group of medicines that have been very beneficial. So if you've had a heart problem, we try to get you on an ACE inhibitor. ACE inhibitors are what I would refer to as the prill drugs. So these would be things like lisinopril, captopril, enalapril. There's a bunch of them out there. The trade names differ a little bit from that, but the generic names generally have the prill in them. And these medications we try to get everybody on if at all possible. Initially marketed for blood pressure control, then we found out that they were used to treat congestive heart failure. Then we found out they help to treat diabetes. And then we found out that it helps to prevent heart attacks and strokes as well. Things called beta blockers. These would be the OL drugs, metoprolol, atenolol, propranolol. So the OL drugs are things called beta blockers. And we know that these medicines, if you've had a heart attack, help to prevent second heart attack. So very important as well. How about primary prevention? So we're going to shift gears. So that was all secondary prevention, some of which applies to people who haven't had heart problems. But in primary prevention now, we're looking at trying to prevent problems from happening. In terms of lipid management, there's new guidelines that came out. Generally speaking, we want your LDL less than 100. Once you have heart problems, we like it less than 100. But if you're at risk, we want less than 130. How about antiplatelet therapy? I mean, who should take aspirin is another big issue. If you haven't had a heart problem, should you take aspirin? Generally, if you're at risk for heart problems, and generally 3 or more risk factors put you at risk for having heart problems, it's a good idea to take an aspirin as long as you don't have ulcers or perhaps other problems with the brain, such as, there's some things that can cause some bleeding in the brain you need to be careful with and talk to your physician about. But generally, antiplatelet therapy is quite effective in terms of preventing heart problems. They did studies in the United Kingdom. They also did studies in the United States. A little bit of discrepancy between the two studies. I believe it was the US study that said it was beneficial just to put everybody on aspirin, and the United Kingdom trial was a little more restrictive and said no, there's a little too much bleeding. But by and large, if you have 3 or more risk factors, it's not a bad idea to be on aspirin as long as you haven't had ulcers or other bleeding problems or any sort of previous brain problems. There's also a study that showed that aspirin helps to prevent colon cancer. So you can kind of get 2 birds with 1 stone as well. ACE inhibitors, there's something called the HOPE trial, which stood for Heart Outcomes Prevention Evaluation. And this was a trial that was completed about 2 years ago that showed that these medicines help to prevent heart attacks and help to prevent strokes. So a very good group of medicines to be on for treatment of blood pressure, perhaps. One of the side effects from ACE inhibitors, about 15% or 1 in 7 patients can get a cough. If you get a cough, you stop the ACE inhibitor, cough goes away. There's some other medicines that are very similar to ACE inhibitors where the incidence of cough is only 3%. But we don't have as much data about those to say they're as effective as the ACE inhibitors. We think they are, but we don't have all that data. How about controversies in prevention? Let's talk a little bit about hormone replacement therapy. I don't know if the Oprah show got into that when I was talking about women and heart disease or not today. But hormone replacement therapy. It wasn't too many years ago we said, as cardiologists, boy, we love postmenopausal estrogen replacement. We thought this was the next best thing to sliced bread. And out came something called the HERS trial, H-E-R-S, which I think stood for Hormone Estrogen Replacement Study. And what they found in the HERS trial was they took a group of women that all had coronary disease, they put them on estrogen, and what they found out was that if you put people on hormone replacement therapy, the risk of having heart attacks went up the first year. But after years 3 and 4, the risk went down. So it just really threw our world into chaos in terms of what to recommend to patients. So generally now, the recommendation today is if you're on hormone replacement, you can stay on it. If you're not on it, you got to think twice before you start it. And to make sure you look at all the other things that are involved in terms of risk prevention rather than jumping first to perhaps hormone replacement therapy. Vitamins we touched on a little bit. There's the homocysteine arm, which would be the vitamins B6, B12, and folic acid, which help to lower homocysteine, and then the vitamins E and C that help to prevent the oxidation of fats. There's been some controversial data about the vitamins E and C. Some studies say yes, some studies say no. And currently that's been throwing a little bit of chaos as well. I don't think our data for the vitamins E and C are as strong as the homocysteine arm, which would be the B6, B12, and folic acid. How about some of the other supplements, things like coenzyme Q10? I think there's weak data on that to recommend it to everybody. Minerals, there was a book published that said dead doctors don't lie. I kind of take that one to heart sometimes. That guy was pushing minerals. I think he's pretty wealthy now. And I'm not sure of all his claims in his books. There are certainly some minerals that may be of benefit, selenium being one of them. Garlic, I've got a lot of patients on garlic. A lot of people take it. I remember being a cardiology fellow and doing rather in-depth research on looking at the benefits of garlic and onions. And I can tell you that most of that literature comes from the Eastern literature. Most of those results come from the Eastern literature. There is something in garlic and onions that's very similar to aspirin. And whether that's the benefit to it or not, we don't know. And there's extreme controversy about should the garlic be crushed, should it be fried, should it be dried, and does that alter it as well? So there certainly are some benefits to garlic. You may lose a few friends if you take too much of it, but there are certainly some benefits to eating garlic as well. I didn't put alcohol down here, but I will mention alcohol. Alcohol in moderation does seem to be a protector in terms of prevention of heart problems. It's a little bit difficult for us in the health profession to recommend everybody go out and drink when there's other hazards associated with alcohol intake, but certainly the red wines have been shown to be some benefit. And I'll be happy to answer those questions later on as well. How about screening? How do we know who has heart problems, and how do we find it before maybe you have it? There's a simple office test just to look and see what the pulses are in the feet and what are they in the arm. And we can check those to see if there might be any blockages. The blood pressure in the legs should be very similar to what it is in the arms. If the blood pressure in your legs is low, then we know you might have blocked arteries, because it should be the same. And as blood pumps from your heart down to your legs, if there's a blockage in a leg artery, you might have a lower blood pressure in your leg than you do in your arms. One of the other things I want to talk about in terms of a screening device, and you may see this, especially if you drive through some of the larger cities, is you can get a CAT scan. And a CAT scan looks for coronary calcium. And you'll see these things. One of them was called Heart Check America, but you'll see them advertised on the radio. And the reason you see them advertised is because these things are not covered by insurance, and it's all out-of-pocket expenses. So these things cost about $500. You go in it, you get a CAT scan done, and it tells you your calcium score. In other words, as arteries develop plaque, the more plaque you have, the more calcium gets laid down in that plaque. And so if you get a calcium score that's very high, then the theory is that you may have more blocked arteries. The problem is that everybody who has one of these things immediately gets their score, comes to the office and says, here's my score, what do I do? Well, you need a stress test. I need to know, is it significant or not? And so I've got to do a stress test to see if those blocked arteries are of significance or not. If the stress test looks fine, then I'm going to tell you to modify your risk factors. If you just come in to begin with and said, gosh, I've got all these risk factors for heart problems, what do you think? I would have said, I think you need a stress test to see what your arteries look like, and then we'll go from there to begin with. So unfortunately, I think a lot of people are getting misled to a very, and unfortunately, I think a lot of us do this. We want the quick, easy fix, which is, let me go get in a CAT scanner, let the thing whip around a few times, and then tell me if I've got blocked arteries or not. And unfortunately, it's not that easy. And I'm just afraid that too many people who get that and maybe have low calcium scores are ignoring some of the other risk factors that need to be treated. So that's my gripe with that. It's not as bad today as it was maybe about 5 years ago, but I would get at least one patient a week in the office asking about this test. And most of them were in the financial world, stockbrokers, because they all want to know, is that the stock to buy? It's calmed down a little bit, but we talked about C-reactive protein and some of the others. How about some special issues of prevention in women? Those of you who did see the Oprah show today, I don't mean to be plugging Oprah so much today, but women tend to be undertreated and underdiagnosed when it comes to heart problems. Their symptoms tend to be a little different than men. They tend to delay their presentation to the emergency room because of that. And so they tend to be undertreated and underdiagnosed. The risks to women tend to be underestimated because their disease is usually later in onset. In other words, they tend to be a little bit older than do men. But as you saw today, if you happen to see the show, it can happen in very young women. I can probably count on one hand the number of premenopausal non-smoker women I have in my practice who've had heart attacks. I can give you a whole lot of patients who are very young, premenopausal, who are smokers who've had heart problems, but very few who are premenopausal non-smokers with heart problems. But it happens. The first event in women is more likely to be lethal than it is in men, in part because they're a little bit older when they present, also in part because they tend to have more diabetes associated with their heart problems as well. On average, women have angina 10 years later than men, and their first heart attack is usually 15 to 20 years later than men. It's probably a little more important that we treat this metabolic syndrome in women because diabetes is a big issue when women present with their heart problems. So it's probably a little more of an issue to try and be more aggressive with treatment of that metabolic syndrome in women. In other words, tries to raise the HDL or the good cholesterol, try and lower the triglycerides, keep the blood pressure under control, and the weight loss. There are risk calculators to figure out what our risks are going to be. You know, it's kind of like reading the Good Housekeeping magazine, or Cosmo would be a good example. You know, how good is your sex life? And you take the test, and you get 4 points for this, 2 points for that, 1 point, 0 points for this, whatever the number is. So there's points that you can assign to do risk calculations. And so what I thought I would do when I was preparing this talk was I would do my risk and figure out what my risks were. And the title of this talk that I was giving today was about prevention. The only cure for coronary artery disease is prevention. And what I should have titled the talk was that this was the talk that saved my life. In terms of when I started doing my points, and just for my age of 45, I get 11 points. When I looked at my LDL, my cholesterol has always been 220 until I checked it before I gave this talk, and it was 276, which really scared the heck out of me. And my LDL were 176. Again, LDL should be at least below 130 and preferably below 100. My HDLs are great. My triglycerides were 202, and if you have over 200, you got the 4 points. I don't smoke. I don't have diabetes. I do have a family history of heart problems, which is part of why I do this. It wasn't that I just went into cardiology because there's 3 arteries, 4 chambers, 4 valves. But that was one reason why I went into it. Blood pressure, systolic blood pressure, if anything over 120 was enough to give you 2 points. So my total points were 35 points. If I did nothing to modify my risk factors, despite my age of 45, my chances of having a heart attack in the next 10 years were 4%. Just by lowering my cholesterol down to an LDL of 100, my risk would be less than 1%. So a huge reduction just with modifying my cholesterol. So ultimately, again, and to reiterate, if we can prevent coronary disease, I really think ultimately that's the only cure. And everything else just represents a treatment, be it bypass, be it stents, or be it medications. So with that, I'm more than happy to entertain questions and answer any questions you guys have in terms of prevention or anything other issues with heart problems. Yes?
You as a heart doctor, do you always have this fear on your mind? Do you see so much of it?
Yeah. The question is with me as a heart doctor, is this something where I think about or have on my mind? It is. You know, my father had heart problems, 4 pacemakers, couple heart attacks, so it is an issue that's in there. You know, and it's the #1 killer in America, #1 killer in both men and women. So given the odds, it's certainly going to be one that gets me. So you certainly think about it.
How can you raise your good cholesterol?
Yeah. How can you raise your good cholesterol? There are very few things that raise good cholesterol, and I can do it on one hand. Low good cholesterols are primarily genetically determined. So you can thank your parents if you have a low good cholesterol or low HDL. But things that raise it are diet and exercise, alcohol, and niacin in high doses. But I want to warn you, don't take niacin if you're on Lipitor or Zocor or any of the other statins, because the risk of myositis or inflammation of the muscles goes up drastically.
Well, I just had my blood work done, and my good cholesterol was 44.
Yeah.
And that's too low, isn't it?
Good cholesterol, anything over 40 is fine. So if your HDL is above 40, that's a good number. So 44 would be excellent.
The bad cholesterol was 106.
That's a good number, 106 for an LDL.
But my cholesterol, or my triglycerides were 229.
There you go.
Now what do I do about that?
Triglycerides can vary significantly over the course of the day. So it's important when you have your triglycerides measured, if they're elevated, to make sure you fasted for about 12 to 14 hours. So if you have anything to eat between that time, that can account for a little bit of fluctuation.
No, I didn't.
And so if that triglyceride of 229 that you discuss is truly not a 12 to 14 hour fast, I wouldn't be that alarmed by it. I'd recheck it after a 12 to 14 hour
Well,
fast.
in November it was 144.
Yeah, there you go.
So that's too much fat, too much sugar.
Sugars do play a role in terms of triglycerides, which is why diabetics in particular have higher
Well, I
triglycerides.
am a diabetic also.
Yeah.
But I don't eat, but very, very little sugar. But I eat a lot of fruits and vegetables.
And some of those sugars do get converted to triglycerides.
Yeah.
Yep. Yes.
I was up to have the, whatever you call it, angio.
Yeah, heart catheterization or angiogram.
It's been about 6, 7 years ago. I went up because I didn't do well on a stress test,
Right.
but you found nothing wrong up there. But I couldn't go up a flight of stairs without getting winded. And just before I went for the test, I started taking some aspirin, and that seemed to help. And since I had the test, I've been taking half an aspirin every day, so I recently switched to the 81,
Yeah.
but I still get winded. I don't know
You brought up a couple of
how it
interesting.
goes.
Yeah,
I've worked with stress. I was under a lot of stress all of my working days. I would have thought that would have led up with retirement, but I still get winded. I don't get enough exercise, I know that.
Yeah. You brought up a couple interesting issues, and one of which is just stress testing. And in terms of the accuracy of stress testing, if you look at just routine treadmill examinations in men, they're fairly accurate. And I would put that accuracy of about 80%. If you look at the accuracy of a routine treadmill in women, you're looking at about a 50% accuracy. So that's no different than saying, coming into the office and asking the question, do I have a heart problem? And I get a quarter out, and we go heads or tails. It'd be a lot cheaper too. So it's very important, more so in women, is to combine the stress test with pictures. Either be it a stress echo, where we ultrasound your heart, and before and after the stress test, or a stress thallium study where we inject some nuclear stuff. If you look at the accuracy then, we've now increased it to about 85 to 90%. In men, it's also about the same with stress echo, about 85 to 90%. Men who have an abnormal EKG also have poor predictability from routine stress testing, so it's important to combine that with pictures as well, either stress echo or stress thallium. There are other things that cause shortness of breath that can be heart-related. Sometimes hypertension can cause it, sometimes poor conditioning can cause it, and also certainly lung problems can cause it as well. So a whole host of things can cause that.
Sometimes I've noticed if I do get stressed, I start getting chest pains, and I kind of have to make myself just relax and take some breaths.
With stress, what can happen is you make more adrenaline. Adrenaline makes the arteries constrict. It also makes the esophagus constrict. That alone can produce chest discomfort as well.
I take 2 Aleve about 3 times a week because I have much back pain. How about taking that 83 milligrams of aspirin also every day?
Yeah, you brought up about 3 things that go through my mind in terms of asking about Aleve and aspirin and which one to take. It is recommended that if you take what you would call, or what we would call, a non-steroidal agent like Aleve or Ibuprofen or Celebrex or Vioxx, you still take your aspirin because the others don't do the same thing that the aspirin does. So you still need to take your aspirin. There was a recent report that looked at the use of ibuprofen in conjunction with the aspirin, and if you took ibuprofen, it seemed to block the effect of the aspirin. However, if you took things like Aleve or any of the other non-steroidal agents, it didn't seem to do that. Ibuprofen was either the only one or one of the few that blocks the effect of aspirin.
So it's
So-
okay to go ahead and take the
Taking Aleve is fine with taking aspirin. Yep. Yes.
Back to cholesterol, at one
Yeah.
time, the doctor gave me a ratio, you take the good cholesterol into the bad cholesterol. Is that still a good?
Yeah, the ratio that I'm more familiar, when you look at the ratio to look for, it's the total cholesterol divided by the HDL. And that's a general number. You want less than 4.5. If you look at things like the Dean Ornish diet, or you look at where there's been reversal of plaque, in other words, plaque that used to be 60% and is now 55% or 50% blocked, those people typically had ratios less than 3.5. And that brings up something as I'm thinking about plaque reversal. If you look at things like the cholesterol-lowering medications, and you take people with blocked arteries, you put them on cholesterol-lowering medicines, you do follow-up angiograms, and you looked at the amount of blockage, there's not a whole lot of change in the blockage. Yes, there's a little bit less, but there's a significant reduction in the amount of heart attacks. And what we think we're doing is that we're modifying the materials that are in that plaque. We're stabilizing the plaque, so it's less likely to make a heart attack happen. We make that plaque more hard plaque as opposed to soft plaque. Soft plaque has more cholesterol and fats in it. Hard plaque has more cellular elements, things we call fibroblasts or other cells and tissue in it, and it's more firm and it's less likely to rupture and cause a heart attack. So when you look at using medicines, these cholesterol-lowering medicines, yes, we're making the plaque a little bit less, but what we're really significantly doing is changing the composition of the plaque by making it have less cholesterol and fats in it. Yes?
I find that my stomach gets a little upset, it gets the heart action a little bit more. Is that natural?
Yeah. The question was in terms of stomach upset and getting some heart symptoms as well. Unfortunately, the same nerve that goes to your heart goes to your stomach. And it's the vagus nerve. And that nerve, which is why sometimes, people come into the emergency room, they think they're having a heart attack, and they say, oh, it's your hiatal hernia. But remember, common things are common. Hiatal hernias are common, but so is coronary artery disease. So you got to make sure you don't have the bad thing going on before we just say, it's just your hiatal hernia, don't worry about it. And the reason for that is when your stomach's, upset and angry and getting irritated by too much acid, it's pulling on that vagus nerve, but so is your heart pulling on that vagus nerve when you're having a heart attack. And the brain can't distinguish the two. So that's why the symptoms between the two seem very similar. You may have heard the stories before where somebody gets their leg cut off and they'll say, boy, my right toe's killing me. Well, there's no right toe left anymore. But the nerve that used to go to that right toe is still angry and upset over something or getting irritated, and the brain still has that image of a right toe being on there and says, my right toe's killing me. But there hasn't been a right toe on there for years. Yeah. Yes?
What did you say your opinion of CQ10 was?
My opinion about coenzyme Q10 is that I don't think there's enough data to recommend it. What I would say out there is that feel free to take it. I don't see anything that says it's going to harm you. I just don't have a lot of information to say it's good for you.
I think Europe's done a lot more than we have.
Yeah, that may well be the case. Yeah. Yeah.
Now, I do have a hiatal hernia and have acid reflux, and I take Tums. Is that recommended for somebody that has diabetes and a heart problem?
Yeah, Tums is fine.
Okay.
Tums is fine. A little calcium in there for you too, help the osteoporosis.
See, I've got that too.
Yeah, there you go.
Well, actually, it's not to that spot yet, but I
Yeah.
do have any other bones that do take Actonel, I think it is.
Mhm.
Yeah.
You bet. Yes, over here.
Alcohol, you
Mhm.
mentioned that. How about that in conjunction with all the medication you're taking?
Yeah. The question was about alcohol and all the other medication you're taking. With the statins in particular, and the statins would be the Lipitor, Zocor, Pravachol, Lescol, used to be Baycol, which they pulled off the market, Mevacor, which is now generic, so any of you on Mevacor, it is now generic. As long as you've had your liver enzymes checked, that's fine. But alcohol in moderation is not a problem with most of those medications. And in moderation, that means 1 or 2 at most a day. So be it, glass of wine, a beer, 1 shot. That's it. It does seem as though there's something about red wine that's a little bit better for heart patients than are the others, and whether it's something in the skins of the grape are important. If they just did a recent study that looked at rosés and whites, they didn't have the heart protection that the reds did. There's also other studies that have looked at grape juice and found out that if you had grape juice daily, that was beneficial for you as well. Yeah. Yes, in the back?
In box of Cheerios, it says may help lower your cholesterol. Is there much weight in that?
And the question was a box of Cheerios, and it says that it may lower your cholesterol. There is evidence to say that oat bran alone will do it. Metamucil will lower your cholesterol, but it's going to lower your cholesterol 5–6%. To get down to the other numbers that the Mevacors and the Lipitors and the Zocors get down, which they lower at 35%, that's the difference between the two. So Cheerios is correct in order to put that on their box. It will lower your cholesterol. But that's why oat bran does it alone, that's why Metamucil does it, and that's why something called cholestyramine, which is the old powder before we had the Zocors and the Lipitors and the Pravicols, we had something called cholestyramine, which was a powder you mixed and drank it, and it kind of sucks up all the cholesterol in your intestines. That's what oat bran does. That's what Metamucil does. It sucks up the cholesterol in your intestines, and then when you have a bowel movement, you get rid of it. Yeah. Yes, in the front.
Are side effects severe with different medications?
Sure. The question was, are the side effects severe for different medications? Yeah. You know, it depends on which medications.
Well, like I take Niaspan,
Yeah.
and every once in a while I get so hot, I mean, I'm on fire, and it lasts all night.
Yeah.
I mean, tell you.
Yeah. With niacin in high doses, which is what it takes to affect the HDL and affect the LDL, one of the side effects can be flushing or hot flashes as you describe it. The Niaspan product, which is a once-a-day product, as opposed to regular niacin, which is a 3-times-a-day product, has a little lower incidence of flushing than does the regular niacin. If you take aspirin before you take niacin, you can help prevent the flushing reaction.
Well, I take aspirin in the morning.
Yeah, and you take your Niaspan in the evening.
Niaspan at night.
Yeah, you might try taking your aspirin at supper time and then take your Niaspan at bedtime, because aspirin helps to prevent that flushing reaction. Yep. Yes?
For pain relief, which is the stronger, Advil or Aleve?
Yeah. So the question is, for pain relief, is Advil stronger or Aleve stronger? I would say they're comparable, but the advantage of the Aleve is it's generally a twice-a-day pain reliever, as opposed to Advil, which is generally a 4-time-a-day pain reliever. So if you want quick, immediate relief, I'd tell you to take Advil. If you want to have more sustained relief over the course of the day, I'd tell you to take Aleve. So with Advil, you're kind of doing this in terms of your pain control, whereas Aleve, you're doing more like this. Okay. Yeah. Yes?
With high cholesterol, you start on Zocor. How long before you should have a second cholesterol check?
Yeah. So the question was, when you start on Zocor, how soon should you have your second cholesterol check? Generally about 6 to 8 weeks. And that should include a check of your liver as well as the whole lipid profile. Yep. Yes?
You take Coumadin, can you take aspirin?
Yeah. So the question is, with Coumadin, can you take aspirin? Boy, there's times when I really feel old, and I was going to say in the old days, which was really more when I was in training, we used to tell patients never, ever, 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 ever take aspirin with Coumadin. And we don't do that anymore. We tell people it's okay. What we've done over the course of the years is we don't thin the blood as much today as we used to with the Coumadin. And so by bringing down the amount of Coumadin we need to give patients, we've been able to slip in a baby aspirins with it in a lot of patients. So there are a number of patients who we do use both aspirin and Coumadin. I wouldn't do that, though, without talking to your physician, but we do use...
I take Tylenol, but
Yeah.
I don't take aspirin, but I take Coumadin.
Yeah,
I only take a half for 4 days and a whole one on the 5th day.
right. Well, as I say, we used to not use the two together, but we do now, in some patients, use both aspirin and Coumadin. Yep. Anything else?
I will say when I was eating oatmeal,
Mm-hmm.
I ate it every day for about 6 months. My blood, my triglycerides and my cholesterol both were down considerably. Then I got so kind of sick of it. And that's when things started raising up again. I wonder.
Sounds like the oatmeal was beneficial for you.
Yeah, I I mean, does that sound dumb? Or?
No, I can understand both sides of it, that it was effective and you got sick of it.
I was also riding my bike at least 18 miles a day.
Yeah.
Well, then I broke my tailbone and that ceased. So now I'm doing good if I can ride it 9 miles a day.
Yeah.
But I think between the oatmeal and riding my bike kept that cholesterol and
Absolutely. Exercise plays a big role, you bet.
and I think it helps keep my blood sugar down.
Mm-hmm. Yes.
That just made me think, as far as exercise, for the heart, is it mainly the, what do they call it, aerobic exercising as opposed to weight? I know you're supposed to do both.
Yeah. So the question is the aerobic better than the weightlifting, in particular in terms of exercise? From a heart standpoint, the aerobic is of greater benefit. You're right, weightlifting is important in terms of adding that into your program. I used to say the weightlifting gave you the Cadillac body and the Volkswagen heart. If that's all you're going to do is weightlift. Yep. So you have to get on the treadmill and do some of the other things to get the Cadillac heart too. Yep. Anything else? Great. Well, thanks for having me here today. It was a pleasure visiting with everybody, and I'd be happy to talk again anytime in the future. So thanks for coming out on a cold night. Thank you.